Good morning. Today's topic of discussion is dental avulsion. So, dental avulsion is the complete displacement of a tooth from its socket in alveolar bone owing to trauma. So, as said before, trauma is the main etiology for avulsion. It can result from sports or other accidents which can cause teeth to fracture, loosen, or even completely get knocked off from its socket. So management of dental avulsion can be either at the site of injury and in the dental office. So at the site of injury, once the avulsed tooth is found, rinse it with water and reimplant the tooth. When immediate reimplantation is not possible, please place the tooth in the best available transport medium. So the the most ideal transport media is Hank's Balanced Salt Solution, or also known as HBSS. It is commercially available at the name Save a Tooth. It's a pH preserving fluid and a trauma reducing suspension apparatus. The other physiologic media are the patient's own saliva or milk. It can be used in serious accidents that relegate reimplantation to secondary importance and hence reimplanted when crisis is over. So this is the commercially available transport media, which is very ideal. So how do we manage avulsion in dental office? So if the tooth has been in any physiological media, storage media such as milk or the patient's own saliva, reimplant it immediately. If the extra oral dry time is less than 15 minutes, reimplant immediately if the root apex is mature. Subsequently, root canal therapy may be required after further tests. If the root apex is not closed and it's open, then monitor the tooth for pulpal pathosis. So this is a clinical picture how an avulsion can occur. And if the extra oral dye time is greater than 15 minutes, rinse it with saline and reimplant it only if the root apex is closed, because replanting the tooth with open apex increases the risk of ankylosis also, which is called as replacement resorption. So how do you manage the root surface? Keep the tooth moist at all times. This is to preserve the existing PDL fibers. Do not touch the root surface and hold it only by the crown. Do not scrape or brush the root surface because it will remove all the viable PDL fibers. If the root appears clean, reimplant as it is after rinsing with saline. If you feel the root surface is contaminated, rinse with HBSS solution or saline, and if either of it is not available, you can use tap water. So this is the flow chart of the protocol for management of an avulsed tooth with open apex. Okay, there's a common protocol for this. For that is which you can see it in the blue box. Okay, so that includes reimplanting and repositioning, verifying with an IOPA, placing of flexible splint, start systemic antibiotics, give post-op instruction, advise for anti-tetanus if required, and follow up for 7 days. So this is the common protocol for various criteria. So we'll go to the criteria one by one. So if the tooth is reimplanted immediately at the site of incident, you can directly follow the common protocol. And if the dry time is 15 to 6 hours, the tooth was stored in milk or HBSS solution, soak it in 1% doxycycline for 5 minutes or 50 mg capsule per 100 ml of saline, and then proceed to the common protocol. If the extra oral dry time is 15 to 20 minutes, it is stored wet but non-physiological medium, either tap water or saliva. Change the transport media to HBSS and then follow on to the common protocol. If the extra oral dry time is 0 to 60 minutes and it's with dry storage, first transport the avulsed tooth to the HBSS solution and then follow the common protocol. Then if the extra oral dry time is greater than 60 minutes with dry storage, soak it in citric acid for 3 minutes and rinse well or debride and remove the PDL gently with a scaler. Then Place this cleansed tooth in a solution of sodium fluoride for 20 minutes. So this soaking of avulsion tooth in sodium fluoride reduces the risk of resorption. Then proceed to the common protocol. Then assess need for apexification, apexogenesis or root canal therapy. This is done at a later stage. So next is the protocol for avulsion tooth with an closed apex. So as said before, there is a common protocol which you can see in the grey box. So reimplant immediately at the site of injury if the extraoral time is in limits and it is in HBSS or milk solution. And if the extraoral dry time is between 15 and 120 minutes and it is maintained in a moist condition and transported in a non-physiological medium such as water or saliva, transport the media to HBSS if available, then proceed for the common protocol. If the extraoral dry time is greater than 60 minutes with dry storage, again soak it with citric acid for 3 minutes, rinse well and debride and remove the PDL gently with a scaler. Again place the cleansed avulsion tooth in sodium fluoride solution for 20 minutes and follow the common protocol. And at a later date, after assessing the vitality of the pulp, root canal therapy may be required. So how do we manage the socket? Do not curate the socket if the clot is present. Use light irrigation with saline to dislodge the clot. Do not make a surgical flap unless bony fragments prevent reimplantation. If the alveolar bone is collapsed and prevents reimplantation, carefully insert a blunt instrument into the socket to reposition the bone to its original position. After reimplantation, manually compress facial and lingual bony plates and then proceed for splinting. So how do we splint the tooth? We use acid edge rinse alone with soft arch wire or use orthodontic brackets with passive arch wire. Suture place only if alternative splinting methods are unavailable. Splint should remain in place for 7 to 10 days. However, if tooth demonstrates excessive mobility, splint should be maintained until the mobility is under control. So these are the available splints. This is with the arch wire. This is a titanium flexible splint. Bone fracture resulting in mobility usually require longer splinting duration, that is that range from 2 to 8 weeks. Home care instructions during splinting period include not to bite on heavy or hard food substances, to maintain soft diet and good oral hygiene. The adjunct drug therapy can be oral or systemic antibiotics. Refer to physician for anti-tetanus prophylaxis within 48 hours, chlorhexidine mouth rinses and analgesics for pain management. So endodontic treatment includes tooth with open apex and less than 15 minutes extra oral dry time, reimplant in an attempt to revitalize the pulp. So the main goal for this is to revitalize the pulp. Recall the patient every 3 to 4 weeks for evidence of to record any evidence of palpal pathosis. If pathosis is noted, thoroughly clean and fill the canal with calcium hydroxide and apexification procedure is then initiated. Tooth with open apex in greater extraoral time of 15 minutes, thoroughly clean and fill the canal with calcium hydroxide and recall the patient in 8 to 16 weeks for follow-up. Then tooth with partially or completely closed apex and the extraoral dry time is less than 15 minutes, remove the pulp 10 to 14 days after reimplantation, medicate the canal with calcium hydroxide, obturate the canal with gutta-percha and sealer. Then tooth with partially or to completely closed apex and the extraoral dry time is greater than 15 minutes, perform root canal therapy either intraorally or extraorally. If treated extraorally, avoid chemical or mechanical damage to root surface. Avulsed permanent teeth require follow-up evaluations for a minimum of 2 to 3 years to determine the outcome of the therapy. The most common complications of avulsion are inflammatory resorption, replacement resorption, that is ankylosis, and then tooth submergence. Thank you for your patient listening.